My name is Madison Vaughn, and I'm an occupational therapy capstone student at Lincoln Memorial University, and this is part 3 of my Caring with Confidence series. To provide an overview of what I will be discussing in this presentation, I will provide some statistics surrounding FAS and kinship care. I will be reviewing some definitions from previous sessions. I'll provide an overview of FAS, including signs, symptoms, and presentations, and then discuss some strengths that individuals with FAS hold. Similar to the research relating to neonatal abstinence syndrome, research pertaining to informal and fictive kinship relationships that do not involve the child welfare system is limited in regard to FAS. Most statistics provided are reported for children in foster care or formal kinship arrangements. From the research that we do have available, it shows that on average, a child with FASD is 17 to 19 times more likely to be in the child welfare system than someone without FASD. 30.5% of children with FASD are placed in a foster care, according to a 2024 study. And a study recently published in January of 2026 analyzed 77 children between the ages of 0 to 5 years old that were enrolled in Medicaid with a diagnosis of FAS. The study found that children in foster care received an FAS diagnosis 4.6 to 5.4 months later than their peers who were not in foster care. The time between when they were assessed and when they received a formal diagnosis also took 2.1 to 3.9 months longer. I want to provide an overview of what fetal alcohol syndrome is. Fetal alcohol syndrome is part of a broader category known as fetal alcohol spectrum disorders, which result from alcohol exposure before birth. FAS is one of the most severe forms along the spectrum with effects that are lifelong. Many refer to FAS as a lifelong whole body disorder because it really does impact all body systems. In children suffering from FAS, some symptoms include disturbances within the central nervous system, growth challenges or delays, difficulty with social skills. They might experience challenges with learning and memory, and they might experience communication deficits. Individuals can be diagnosed with partial FAS, which we'll talk about on the next few slides, if they have some of the diagnostic criteria of FAS without all of the features. However, partial FAS is uncommon. While FAS does have specific diagnostic criteria, many people fall under the broader term FASD, and we will talk about some reasons for misdiagnosis or a misdiagnosis in later slides. As I mentioned, FASD is a spectrum, and while I will be covering the different diagnoses on the spectrum in the next couple slides, I do want to emphasize that some children may not have a specific diagnosis as there are not a lot of specialized clinicians or clinics to really differentiate the diagnoses. Therefore, some individuals kind of get lumped into the FAS diagnosis. As I mentioned, fetal alcohol syndrome represents the most involved end of the FASD spectrum. People with FAS will have central nervous system problems. They might have minor facial features. They might have some growth issues. People with FAS can have problems with learning, memory, attention span, communication, vision, and hearing. They might have a mix of these problems as well. And people with FAS often have a hard time in school and trouble getting along with others. Partial fetal alcohol syndrome, or what is known as PFAS, is when a person does not meet the full diagnostic criteria for FAS, but they have that history of prenatal alcohol exposure. They might have some of the facial features, and they will have growth problems or central nervous system abnormalities, and they will be diagnosed with what is known as partial FAS. Alcohol-related neurodevelopmental disorder, or ARND, is when people might have intellectual disabilities and problems with behavior or learning. They might do poorly in school and have difficulties with math, memory, attention, judgment, and poor impulse control. And again, this would also be caused by exposure to alcohol in utero. Those diagnosed with alcohol-related birth defects, or ARBD, might have problems with their heart, kidneys, bones, and with their hearing. They only have problems with birth defects caused by prenatal exposure to alcohol, and they do not show evidence of neurocognitive or neurodevelopmental deficits. It is caused by the impact of prenatal exposure to alcohol on how an individual's organs were formed and or how they function, and it is extremely uncommon. Neurobehavioral disorder associated with prenatal alcohol exposure, or what is known as NDPAE, is when a child or youth will have problems in three areas. The first area being thinking and memory, where the child may have trouble planning or they may forget material they've already learned. The second area being behavior problems, such as severe tantrums. They might experience mood issues, for example, irritability, and they might have difficulty shifting attention from one task to another. The third area is trouble with day-to-day living, which can include problems with bathing, dressing for the weather, and playing with other children. To be diagnosed with this, the mother of the child must have consumed more than minimal levels of alcohol before the child's birth, which is defined as more than 13 alcoholic drinks per month of pregnancy or more than 2 alcoholic drinks in one sitting. According to 2023 data from the National Survey on Drug Use and Health, about 1 in 10 pregnant women report current alcohol use. About 1 in 20 women report binge drinking during pregnancy. Alcohol use is the highest among women who are in the first trimester of pregnancy. Using medical and other records, the CDC has identified that about one infant with FAS is born for every 1,000 live births in certain areas of the United States. According to 2023 data from the National Survey on Drug Use and Health, about 1 in 10 pregnant women report current alcohol use, and 1 in 20 pregnant women report binge drinking. Alcohol use is the highest among women in the first trimester of pregnancy. Using medical and other records, the CDC has identified that for 1,000 live hospital births, one infant is born with FAS in certain areas of the United States. The National Institute of Health has also conducted some studies that have identified that the full range of FASDs in the United States and some Western European countries might number as high as 1 to 5 per 100 school-age children, or 1 to 5% of the population. 10% of women consume alcohol during pregnancy, and of this 10%, 1 in 13 will deliver a child with an FASD diagnosis, and 1 in 67 with an FAS diagnosis. I have provided a visual here. 1 in 10 pregnant women between the ages of 15 to 44 in the U.S. used alcohol in the past month, according to a study that was conducted in 2024 by SAMHSA. A 2008 study revealed that 1 to 5% of first-grade children in the U.S. are affected by FASD, according to a National Institute on Alcohol Abuse and Alcoholism supported study. Alcohol exposure during pregnancy can result in FASDs by interfering with the development of the baby's brain and other critical organs and physiological functions. This can lead to deficits after birth and beyond. Alcohol really disrupts development at any stage, even before the woman knows she is pregnant. I wanted to provide a visual so we can understand how fetal alcohol syndrome occurs. Alcohol is consumed by a pregnant person, and that alcohol crosses the placenta into the fetus's bloodstream. Inside the womb, the placenta is what is providing that oxygen and nutrients to the developing baby. The alcohol reaches the baby by passing through that placenta, and the baby's immature liver cannot break it down efficiently. This toxic exposure, particularly during the first trimester, can really damage those cells and disrupt organ, brain, and facial development, which causes permanent, lifelong physical and cognitive disabilities. Alcohol causes a higher blood alcohol level in a developing baby, and this is because a baby breaks down and gets rid of alcohol slower than an adult does. The alcohol is destroying or damaging developing cells and neurons, which causes widespread damage throughout the baby's body. While alcohol consumption is dangerous throughout pregnancy, it is especially critical during those first 3 months when the baby's brain, heart, and facial features are still forming. Alcohol has great effects on the infant. It can kill cells in different parts of the fetus, which causes abnormal physical development. Alcohol also interferes with the way nerve cells develop and how they travel to form different parts of the brain and their functioning. It can constrict blood vessels, which slows the blood flow to the placenta, which is providing that food supply while in utero, and this causes a shortage of oxygen and nutrients to the fetus. Toxic byproducts are also produced when the body processes alcohol, and these can concentrate in the baby's brain cells and cause damage. I will now go over the diagnostic process for FAS. There is no direct test to assess for FAS. There are no blood tests or other medical tests that can be conducted to confirm a diagnosis. Before the child is born, doctors may find issues on an ultrasound, which would include things like heart defects or growth issues. To diagnose FASD, healthcare providers look at a variety of things. They will first determine prenatal alcohol exposure from obtaining a maternal history. If this is available, it is not always reported, therefore, it is not required for a formal diagnosis. The doctor will also look for central nervous system problems. This can include things like a small head size, problems with attention and hyperactivity, and poor coordination. The child may have a lower than average height, weight, or both. They might have abnormal facial features, which we will discuss in later slides. And for a diagnosis, a caregiver may be asked for any proof they may have of alcohol-exposed pregnancy, proof from the school or another professional documenting those developmental challenges, or baby pictures that show the infant not smiling. I do want to discuss the abnormal facial features that can be found with FASD. However, research indicates a small portion, at anywhere from 10 to 15% of the population with FASDs present with these distinct facial features, which is a common reason for misdiagnosis or a misdiagnosis, which we will discuss on the next couple of slides. These features are less pronounced as the child ages and may not be as noticeable as the child develops. It is also harder to distinguish in children of various ethnicities or races. Some of the key facial features, if they are present, include a thin upper lip, a smooth ridge between the nose and upper lip, small eyes or small eye openings, and a small head size or what is known as microcephaly. Most signs of FASD are recognizable between 8 months to 8 years old. If FAS is suspected, the pediatrician or other healthcare professional may refer the child to an expert with special training in fetal alcohol syndrome. This could be a developmental pediatrician, a neurologist, or another expert. They will do an evaluation to rule out other conditions with similar symptoms to help make that FASD diagnosis. While it may be less obvious in adults, it is never too late for a diagnosis, as effects of FAS are long-lasting and severely impact an adult's ability to live independently. We will talk about misdiagnosis or misdiagnosis now. While criteria exist to determine an FASD diagnosis, one study revealed that in a sample of 547 foster and adopted children, 86.5% who met diagnostic criteria were either misdiagnosed or had never been diagnosed. Misdiagnosis and misdiagnosis across the FASD spectrum has largely been contributed to inaccessible or unknown maternal alcohol use history, a lack of information and education available related to distinguishing FASD from other cognitive and developmental disorders with similar presentations, which we will also get into in the next few slides, and the presence of co-occurring mental health disorders associated with FASD. There is a shortage of providers who are efficient in providing that FASD diagnosis, and this also further complicates the process. As I mentioned, FASD can have similar or overlapping presentations to other disorders. A dual diagnosis is possible, which we'll talk about on the next slide. Similarities between autism and FASD include that the individual might present with sensory processing challenges, cognitive delays, and deficits in executive functioning skills. They may also present with challenges with social skills and interactions. Similarities between Williams syndrome and FASD is that the individual may share similar facial features like in the ridge of the nose or eye openings or a small head circumference. Williams syndrome is a genetic abnormality with the deletion of chromosome 7. Similarities between those with FASD and ADHD, they might share similar symptoms like impulsivity and difficulty maintaining attention. There are medications to treat ADHD, as we know, but just like with autism, FASD is lifelong and uncurable. Some children are given medications at birth to treat withdrawal symptoms from alcohol, but ultimately the effects are long lasting. Both FASD and autism are underdiagnosed. Data on the association between FASD and ASD is limited. Prevalence data on both conditions is limited because of this. To give some perspective, FASD affects 2 to 5% of live births in the US, while autism affects 1 in every 54 children. Some research shows that the prevalence of autism in children with FASD was 2.6%, which is almost twice the rate in the general population. ADHD affects 1 in every 10 children, and those with FASD are 10 times more likely to meet diagnostic criteria for ADHD. I will now cover some symptoms and presentations of FAS. We already talked about the facial features that can be present, but just a reminder, there is a low percentage of the population with FASDs that this shows up in. There can be slowed physical growth, both at birth and throughout the lifespan. It may also take longer to reach developmental milestones, including sitting, walking, and communication skills. There might be challenges with vision or hearing. There might be a smaller head or brain size, which I've included a visual for. There might be changes with development of the heart, kidneys, and bones. The individual might experience poor coordination and balance, and they may also be jittery or hyperactive. They may have difficulty with executive functioning or those higher level tasks. They may also experience challenges with things like memory, learning new skills, understanding the weight and consequences of the decisions they make. They may have poor judgment or poor risk calculation, and they may struggle with attention and the concept of time. They may also struggle to plan and organize tasks, and they may have shorter attention spans. They may also repeat mistakes because they genuinely forget rules or steps, even moments after they are explained to them. This is not manipulation, it is a struggle with that working memory. Children with FAS struggle here not because they are defiant, but because their brain makes these tasks hard. Many children with FAS also experience challenges with social skills, and they often misinterpret social signals. They may trust strangers or older peers too easily as well. They tend to be very interested in having social interactions and they may appear very friendly. However, they lack the ability to set and respect boundaries and have no sense of stranger danger. When they do engage in social interactions, they often lack the interpersonal skills necessary to move the interaction forward in a positive way. They may make inappropriate statements or ask inappropriate questions and can be easy to manipulate. They may have difficulties with compromising, cooperating, or taking different roles with other children or difficulty with sharing. They can be hyperactive or have impulsive behavior that is difficult to manage from the standpoint of their interaction partner. Children with FASD struggle with social cues and often misunderstand or misinterpret facial expressions and eye gazes from other people. This is due to brain-based damage that affects their social cognition, impulse control, and judgment. This is sometimes referred to as indiscriminate friendliness, where they have that reduced sense of fear or stranger danger, difficulty interpreting social cues, and a desire for social interaction despite lacking boundaries. Children with FAS do experience challenges with school performance. They may have difficulty with understanding abstract concepts and struggle with math. They may have some speech language difficulties. And research shows that they have an increased need for special education services and they are at a higher risk for poor academic achievement. They may also experience challenges with attendance and interacting with their classmates. Specialists will look for behavioral challenges that result from damage to the brain. These behaviors often come in clusters and are magnified when the child enters a school setting. This is because they are starting to learn to behave according to norms that are challenging for them to maintain. They may have difficulty soothing, especially as an infant. They may experience sleep and feeding challenges such as that suck and swallow reflex, frequent acid reflux, or frequent spitting up. They may have sensory issues such as becoming overstimulated, or they might be under-responsive to stimuli. They might have difficulty with change, transition, or new experiences, and a lot of them present with insecure or anxious attachment. Anxious attachment is an insecure attachment style rooted in childhood, and it is characterized by a deep fear of abandonment, low self-esteem, and an intense need for validation in relationships. It can be caused by inconsistencies in caregiving and lead to clingy behavior, high anxiety, and difficulty trusting partners. Treatment involves therapy, fostering self-awareness, and developing secure behaviors. FASDs lead to trouble controlling emotions or reacting to situations appropriately. Children with FAS may experience outbursts during social situations due to their lack of self-control, and they may also struggle to recognize other people's emotional needs and respond accordingly. As expectations grow with age, the brain differences remain in those with FAS. Teens and adults may seem competent but struggle with decisions, risk evaluation, and independence. Research shows that almost 80% of adults with FASD are unable to live independently. It is often an invisible disability, so high expectations are placed on adolescents with FASD, but they are unable to carry out those expectations a lot of the time. Some common presentations in adults include breaking rules and laws, alcohol or recreational drug use, challenges with independent living, difficulty maintaining or finding employment, and early death by accident or suicide. They may have trouble managing money, including budgeting and spending. They are also 23 times more likely to have an intellectual disability, and this can make planning for their life very difficult. Because of higher rates associated with depression, anxiety, and other mental health disorders, these individuals may also struggle to cope with challenges throughout their lifespan without therapy or counseling. They are more likely to interact with the criminal justice system, and they often lack impulse control when making decisions. Unfortunately, many also do not understand the consequences of their actions, as mentioned earlier. Because of their challenges with social skills, it can also make it difficult for them when forming healthy relationships, as they may not have the skills for communication and boundaries. I do want to talk about some of the strengths in individuals with FASDs. It is easy to focus only on challenges, but these individuals have a lot of strengths too. They often have strong self-awareness in that they are aware of their strengths and challenges. This can help them advocate for themselves and also offer advice to others with similar experiences. They show good receptiveness to support, which helps with forming relationships with others and feeling comfortable to seek and receive support. They show good capacity for human connection and are often described by caregivers as empathetic, helpful, and affectionate. They consider challenges as opportunities for growth and are very resilient, and they have often fought through trauma and adverse events and therefore show good potential to overcome life's obstacles. In studies specifically looking at strengths in individuals with FASD, many researchers interviewed caregivers of those with FASD, and caregivers often describe the individuals as loving, kind-hearted, joyous, generous, and caring. They also often spoke of the individual's effort and persistence. I wanted to provide some additional resources. On YouTube, there is a series called Alcohol Stories, and there are several videos discussing the impacts of alcohol, personal stories, and education about substance use. There is a podcast hosted by Patty Casper, who has lived and professional experience with FASD, and it is titled Living with FASD. It is an interview-styled podcast, and Patty works to provide education on FASD, challenge the stigma surrounding it, and provide a community for those experiencing or caring for someone with prenatal alcohol exposure. The CDC also has a YouTube series called Lived Experiences with FASD, where individuals share their experiences and challenges, but also recognize their growth and strengths. These are my references.